The primary mechanisms, one is induction of innate immunity through secretion of defenses and human cathelicidin LL37, which have antimicrobial and anti-endotoxin activities. So innate immunity means that it doesn't matter what the organism is, virus or bacteria, it will attack them all. Now, there are also innate and also non-innate mechanisms that are related to particular organisms. In other words, the body learns to react to perhaps influenza or tuberculosis or something. But now vitamin D also regulates the chemokine and cytokine production in the anti-inflammatory direction to prevent excessive tissue damage. And this is very valuable since it is excessive reaction to infection that lead to the dangerous cytokine storms that will damage the tissue, like the linings of the lungs, and cause a lot of inflammation. And it turns out that as people age, they're more likely to have the vitamin D regulation not become overactive. And so older people are more likely to die from infectious diseases than younger people are. I published a paper in 2009, sort of an analysis of the effect of solar UVB and vitamin D on case fatality rates from the 1918-19 influenza pandemic in the United States. So what happened was the Public Health Service in the United States went to 13 communities and had people go door to door asking residents, did somebody in this household die during the pandemic? Did they get the influenza and did they die? And so that's a case fatality rate they were studying. And what I found was that the deaths were less in the South and in the Southwest, higher in the North and Northeast. And so that meant that if I looked at the July UVB dose, there was about a 28% reduction. Well, it was stronger reduction for that, and the rates of pneumonia as a complication were also very strong. Similar results found for wintertime UVB. The hypothesis was that UVB, through production of vitamin D, reduces the severity of influenza as well as greatly reducing the risk of pneumonia, the main cause of influenza. So they could kill the pneumonia virus as well as bacteria as well. So I published a paper in Nutrients in 2020 in April. Now, I published in Nutrients because Nutrients publishes very rapidly. It does have peer review, and it's very vitamin D friendly. So had I tried to publish this in a mainstream journal, it might have taken 6 months to a year and would have not been the first paper published pointing out that vitamin D could have played a major role in protecting people during the pandemic. So the evidence I use includes that the outbreak occurred in winter, a time when 25-hydroxyvitamin D concentration is lowest, that the number of cases in the southern hemisphere near the end of summer is low, that vitamin D deficiency has been found to contribute to acute respiratory distress syndrome, and that case fatality rates increase with age and chronic disease morbidity, both of which are associated with lower 25-hydroxyvitamin concentrations. So, as I mentioned, this did stimulate other research analysis, but because Big Pharma sees vitamin D as a threat to income and profit, and to the vaccines that we're developing and the expensive drugs that we're developing for preventing and treating COVID. There was a media blackout on vitamin D. The medical system had doctors and hospitals not use vitamin D and other repurposed drugs, and the benefit was largely not available. However, if you come to 2024, a meta-analysis, there was a summary of all the studies on vitamin D supplementation using 16 publications. It found that vitamin D supplementation has a protective effect against the incidence of COVID-19, reducing it by 60 to 68%, 60% in general, and 68% regarding ICU admission. So this meta-analysis suggested a definitive and significant association between the protective role of vitamin D and COVID incidence and ICU admission. Turning now to another infectious disease, periodontal disease or periodontitis is mainly caused by infection and inflammation of the tissue around the teeth, often causing shrinkage of the gums and loosening of the teeth. Vitamin D deficiency is a major cause of periodontal disease, as is poor diet. Vitamin D reduces risk through induction of human cathelicidin that kills the damaging bacteria, thereby reducing inflammation, and by suppressing matrix metalloproteinases or extracellular enzymes known to increase gum destruction. It's been shown that periodontal disease is associated with 57 types of disease. I'm not going to even identify the disease. Well, it turns out diabetes is one of the diseases that has the highest correlation with periodontal disease. And it's been shown that there's a two-way link between periodontal disease and diabetes. If you get diabetes, you're likely to get periodontal disease and vice versa. The periodontists have made the claim that since periodontal disease is associated with all the diseases, and since it occurs often before the other types of disease, treating periodontal disease by cleaning the plaque off the teeth will help reduce the risk of systemic and other infectious diseases. Well, I disagree. They have not really shown through clinical trials that treating periodontal disease by their means really has long-term effects on systemic diseases. So we published this paper in Nutrients, and we're trying to convince periodontists and doctors and dentists and even medical doctors that they should treat this like the canary in the coal mine and tell people that, hey, you should be changing your diet, go to a healthy diet, go to which may be more of a plant-based diet, and cut out red meat and processed meat and so on, and processed foods and sugar and so on. And you should take vitamin D. Unfortunately, our medical system is set up to treat disease through pharmaceutical drugs and surgery and so on. And doctors, like I say, do not believe in vitamin D. They consider it the enemy. And so far, they have not accepted our proposal to make changes in their dealing with their patients. Now, pregnancy outcomes is another area, another type of health outcome that's where vitamin D is very, very important. Pregnancy represents a dynamic period with physical and physiological changes in both the mother and her developing fetus. The dramatic 2 to 3-fold increase in the active hormone 125 or dihydroxyvitamin D or calcitriol concentrations early in the weeks of pregnancy, despite minimal increased calcium, demands during that time of gestation, and which are sustained throughout pregnancy in both the mother and fetus, suggest an immunomodulatory role in preventing fetal rejection by the mother. This is by Hollis and Wagner in 2017. And they are the primary, the best researchers on the effect of vitamin D during pregnancy. Another effect showing that vitamin D is very important for pregnancy is that women in all ethnic groups have lighter skin pigmentation, likely due to vitamin D requirements during pregnancy and lactation, than men. And men are more likely to spend time in the sun. This is by Nina Jablonski and George Chaplin, who have spent years going around the world measuring skin pigmentation. This is the implications. One implication is that there's the Barker hypothesis, first described by David Barker in 1968, noting a connection between neonatal growth restriction and small for gestational age status with the risk of heart disease later in adult life, and has become mainstream thinking. Addressing the original question of this review, does vitamin D quality as a substance that supports and upholds the Barker hypothesis? The clear answer is yes. Through its effect on genetic processes, vitamin D deficiency during pregnancy affects both mother and fetus, and at least in the case of asthma, phenotypic expression in the infant or child. Now, Bruce Hollis took part in a study in Iran where they had a stratified randomized field trial. They had women in 2 hospitals, and they gave vitamin D supplementation in one of those hospitals. So 900 women in only one hospital were only observed, not supplemented with vitamin D. The mean 25-hydroxyvitamin D was 11 nanograms per milliliter throughout the study. Now, in the US and Europe, it's no longer possible to conduct a study where the control group is not given at least a minimum amount of vitamin D. So this will not be possible in the United States. Now, the 900 women in the screening site were supplemented with individual doses to raise their mean 25-hydroxy from 11 nanograms to 21 nanograms per milliliter. This is open access, published in 2018. And the results may be a little hard to read, but for preeclampsia, gestational diabetes, and preterm delivery, those who were in the severe deficiency had by about a 50% reduced risk of preeclampsia, and a preterm, maybe a 70% reduction in preterm gestational diabetes and preterm delivery. Those who are in the moderate deficiency had non-significant reductions in several of these outcomes. So this confirms that vitamin D supplementation is very important in pregnancy. Here's a study conducted at the Medical University of South Carolina, the University of Hollis and Wagner. And they included 1,000 sequential pregnant women at their obstetrics center on their first prenatal visit. They measured 25-hydroxyvitamin and gave them free supplements of 5,000 IU and counseled how much to take to achieve 40 nanograms per milliliter. Of course, not all the women did. And what they showed was that those who achieved less than 20 nanograms per milliliter at delivery had about a 37 to 38 week delivery, whereas those who achieve greater than 40 nanograms per milliliter had more like a 38 to 39 week delivery. And they found that the results were independent of race, and they found a 60% lower preterm risk for the patients with greater than 40 versus less than 20 nanograms per milliliter. In terms of diabetes, there was a study at Tufts University called a D2D. It was preterm, I'm sorry, got to change diseases. It was pre-diabetes. Did they go to diabetes with vitamin D supplementation? Now, in this case, they actually supplemented with 4,000 IU per day. And in the original analysis published in 2019, they found that comparing those who were treated with those who were not treated, there was no significant effect on reducing conversion to new onset type 2 diabetes. However, they did a reanalysis looking at the intra-trial vitamin D exposure and serum 25-hydroxy concentration. And they found that for those with, they could look at different levels from less than 20 to 30, 40 to 50, and greater than 50 nanograms per milliliter compared with less than those 20 to 30 nanograms per milliliter. And what they found was that for each increase of 10 nanograms per milliliter in the intra-trial 25-hydroxyvitamin D level, that was associated with a 25% reduction in those assigned to vitamin D and a non-significant 10% among those assigned to placebo. And they found that those who achieved greater than 50 nanograms per milliliter had a 71% reduction compared to those who maintain a level of 20 to 30 nanograms per milliliter. So indeed, high-dose vitamin D supplementation and achieving a high level does reduce the risk of conversion from prediabetes to diabetes. The authors say this is only for prediabetes. I think it might apply to diabetes in general. On the other hand, vitamin D is not the only factor that affects diabetes. I've done other work, and I've looked at other work from Harvard showing that it's really important to have a diet that reduces inflammation and reduces insulin resistance. And such a diet would be low in red meat, low in processed meat, low in the ultra-processed foods. It would be high in green leafy vegetables. Coffee is okay. Have colorful fruits and vegetables. It would have a lot of whole grains, some fish, some legumes, et cetera, et cetera. So one really has to work with both vitamin D and diet to reduce the risk of diabetes.